Hi students, we're going to be going over chapters 15 and 16 for patient care. That includes vital signs, tubes, lines, cardiac cycle, and an EKG or ECG, depending on how you've learned it. Objectives, we'll be talking about homeostasis of the body, vital signs, oxygen therapy devices, and why we need to be careful with our patients when they're on oxygen. We'll also talk about the tubes and lines you'll see in the chest and stomach imaging that you do. The biological definition of homeostasis is the tendency of an organism or a cell to regulate its internal environment and maintain equilibrium, usually by a system of feedback controls, so as to stabilize health and functioning. Generally, the body is in homeostasis when its needs are met and its body is functioning properly. Normally, the feedback that you get is either negative or positive, but predominantly negative feedback is how the body maintains the homeostasis that it requires. Negative feedback, for example, would be like your home thermostat for heat. If your heat is set at 70 degrees Fahrenheit, that's homeostasis for your home. And if the temperature goes below 70, then the thermometer in the thermostat triggers the heater to turn on. And once the home temperature reaches 70 again, then the heater turns off and the home is back to homeostasis. So it's similar in how when things are out of homeostasis, how your body tries to rebalance everything and get it back where it needs to be. It triggers it to try to rebalance things. Positive feedback is the opposite. It's an intensification of a reaction. So for example, blood clotting, when you get a cut that bleeds, platelets start to cling to the injured area on the site and then releases chemicals that attract more platelets, and then the platelets continue this activity until a clot is formed. So that's a positive feedback, a reaction that is an intensification of a reaction instead of a response to a change. Stimulus is the variable that causes a change or an imbalance in your homeostasis. So receptors in the system monitor changes in the environment, and that information is carried through the afferent pathways to the central nervous system or the control center. So information goes then from the control center down the efferent pathways to the effector, or the part that needs to react to help the environment regain its homeostasis. For example, when you have a fever, it's a relatively simple example. So when a person gets a virus and the body starts responding to the virus to fight it because it's an invasion at a cellular level, there's increased cellular activity, and that makes the body temperature rise since it's using more energy to fight the virus to return the environment back to homeostasis. So as uncomfortable as a fever can be, it is actually your body doing the work to help stabilize and heal you and get that virus out of your system. Some of the mechanisms for homeostasis are the vital signs that we check with our patients in the hospital, or things that we watch for. So we're looking at the heartbeat or heart rate, the blood pressure, body temperature, respiratory rates, and electrolyte balances. Not so much. That's not really a system that we're going to look at. All right, so these are our vital signs. Another area that you can recognize pretty readily is the patient's mental state and how they're responding to you. Primary mechanisms that measure directly the body's physiological condition are what the vital signs are. They can be assessed quickly, and as we talked about in the last couple of chapters, this is objective data. It's typically non-invasive, and it is reflective of the patient's immediate condition and also of the patient's response to changing conditions. So if you're in a trauma, this is going to be really important. You know, in a trauma, you're not likely to take somebody's temperature or pulse rate, but you can see some visual things on the patient that might be an indicator that things are the patient needs more help than they're getting right at that moment. So these are approximate normal ranges for human beings. There's really no exact normal. For example, my daughter's temperature when she was little, and I think even still, ranged between 97.2 and 97.7. And so when she had a fever of over 99, her body always reacted to that as if it was a much higher temperature because she ran so low. So everybody has what's a normal range or temperature for themselves, but typically between 97.7 and 99.5 is about where most people run. As far as respirations, 12 to 20 beats per minute for adults, 20 to 30 for children, and I think infants are even faster. I think that's on a future slide we can look at. Pulse for adults is between 60 and 100 beats per minute typically. And people who are athletes or who exercise regularly may have a much lower pulse rate since their heart muscles are much stronger and they work very efficiently. And blood pressure typically needs to be less than 120 millimeters per mercury. And in the systolic stage and in less than 80 millimeters of mercury in the diastolic stage to be in a healthy range. Above that, and your body's homeostasis begins working overtime to correct the environment. So it's a real, It's a real drain on your body when your body has to constantly try to keep working to get your blood pressure back into the right range or your pulse rate into the right range. Okay, so the healthier you are, the better. Exercise is really important for your heart and your health. Body temperatures. The hypothalamus regulates the heat loss with vasoconstriction and shivering, or with vasodilation and sweating. So when you hear someone is diaphoretic or is in diaphoresis, that means they're sweating to dissipate the heat and to cool down the skin and the body. And there are several ways to take body temperature, and depending on where you take it, the temperature might actually vary 1 to 2 degrees based on the area that you're taking the temperature. There's a chart on page 179 in your patient care book that gives you the approximate temperatures depending on whether you take your temperature orally or in the axilla or in the ear, the tympanic, or in the temporal across the forehead, or rectally. You don't hear rectal temperatures being taken real often except maybe on small infants, but the temporal one seems to be the easiest way to get a patient's temperature. Abnormal temperatures. Hyperthermia is, hyper means over, hypo means under, so below the normal temperature range is hypothermia, and above the normal temperature range is hyperthermia. So hypo low, hyper high. When the pulse rate is measured, the second and third digits of your hand are placed over the pulse point and should be counted for 60 seconds for the most accurate assessment. In addition to recording the rate, you need to record the strength and regularity of the beat as well. Is it strong? Is it weak? Is it thready? There's a lot of descriptors for that. Never ever use your thumb, because your thumb has its own pulse in it. So it would be really difficult to determine what the difference between your thumb pulse and the pulse of your patient that you're trying to find the pulse on. The assessment. When you take the pulse, it's the assessment of the heart as reflected in the arterial walls throughout the body. So that means that as the heart beats, it changes the pressure in the arterial walls, and you can feel the beat and the contractions of the heart through the arteries. The cardiovascular system, as a closed loop, then allows the beat to be felt throughout the system. The arterial pulse is a measurement of the heart's contraction rate, because a pulse wave is created when the left ventricle contracts, and the arteries then expand in response to this contraction and increase in volume. Once expanded, the arteries will contract, forcing blood to circulate to the capillaries and then into the veins. The carotid pulse actually is the most accurate reflection of the central aortic pulse. So when you're doing CPR or BLS, that's why you're checking the pulse at the carotid rather than anywhere else. Typically, when you're taking someone's pulse, you're going to do it at the radial artery. If you're doing babies or small children, you may be checking in the brachial artery, which is in the upper part of the arm. So for the most part, you're going to be using the radial artery, and that's the one we will practice with in class. And it's the carotid that you do when you do your BLS training. Pulse rate. Typically, you need to count the rate for 1 minute. And as I said before, it's usually 60 to 100 beats per minute for an adult, and for children, 70 to 120. During CPR, typically the pulse is measured at the carotid, as I was saying. And if your patient's in the hospital, a lot of times they'll have a pulse oximeter, and that will take a pulse rate as well as determining the level of oxygen in the blood. You can also listen with your stethoscope when you can listen to the heart rate with a stethoscope over the left side of the chest. So that's not as common for what we do in our department. You're going to do, like I said, you'll do the radial artery. The pulse oximeter you're going to see in your patients in the hospital. It's typically on their finger. For little ones, sometimes it's going to be on their toe or their earlobe. Other areas it can be placed as well. The oximeter converts light intensity into oxygen saturation and pulse rate values. It's a photoelectric device that helps determine how much oxygen is in the blood. So if you think of it in terms of the attenuation of an X-ray beam. So for example, the more light that gets through the finger to the light receptor, the less oxygen there is in the blood. So when you correlate that with X-ray, the more X-ray that gets through the body to the image receptor, the less dense, like the lungs are, for example. So the more light that gets through, or the more X-ray beam that gets through, for the light, the less oxygen that there is in the blood, and for X-ray, the less density, which is similar to what you would see on an X-ray of the lungs or the chest, because your lung field has mostly oxygen and there's not a lot of really dense tissue to get through. And compare that to less light getting through the finger to the light receptor, the more oxygen there is in the blood. So if you correlate that with bones on an X-ray, so the X-ray beam goes through bone, it's much more dense. and there's less X-ray beam that gets to the image receptor. So same, when there's less light that gets to the receptor, there's more oxygen in the blood. It's more dense. I hope that didn't confuse everyone, but if you have any questions, just send me an email and let me know. But I thought it was a good analogy of what you're doing with your X-rays. Respiration assessment, that's something that you can do after you take the person's pulse. So you take their pulse for 1 minute, and then you take another half a minute or so and watch their breathing and their respirations. So respiration is basically the exchange of gases in the lungs, and is physiologically a result of differences in pressures inside and outside the lungs. So when air goes in, the diaphragm is contracting actually and going down, which expands the chest cavity. And in that expansion, it decreases the pressure in the lungs to below what the atmospheric pressure is, and then air goes into the lungs. When the diaphragm relaxes, meaning the diaphragm goes back up again, this returns the lung field to their original position and increases the pressure in the lungs to above the atmospheric pressure, and then air flows out of the lungs. So it's really related to what's going on. It's all involuntary, so your body's all going to do this all by itself. You don't have to consider it or think of it. Your body is just going to automatically recognize those changes in atmospheric pressures and the pressure inside versus the pressure outside, and the breathing will happen very easily in and out. Ventilation is inspiration and expiration affected by atmospheric pressure, as described in the previous slide. When the diaphragm contracts and moves downward, the abdominal muscles will relax, and it pushes the abdomen contents outward. And then when the diaphragm relaxes, expiration occurs. So when you're assessing the respiratory rate, you want to describe it in beats per minute. So the rate, the depth, and the pattern. Is it shallow? Is it a lot of effort that the patient has to make to get their breath in and out? And is it fast? Or is it slow? Things like that are really important. Is it irregular? That's something you're going to record if your patient's having issues. You'll hear blood pressure measurements referred to as, for example, 120/80. That's about a normal blood pressure for most people. And the top number is the systolic number, which is also the higher of the two numbers, and it measures the pressure in the arteries when the heart beats, when the heart muscle contracts. So usually the ventricular contraction. And the diastolic is the bottom number, which is also the lower number of the two, and it measures the pressure in the arteries between the heartbeats when the heart muscle is resting between the beats and refilling with blood. So is one number more important than another? Well, typically there's more attention given to the top number, the systolic pressure, because that's a major risk factor in cardiovascular disease for people over 50. In most people, the systolic blood pressure rises steadily with age due to increasing stiffness of the arteries, long-term buildup of plaque, and increased incidence of cardiac and vascular disease. And pressure is measured in millimeters of mercury, and that is a measurement that's relative to atmospheric pressure. I posted 2 videos on Blackboard that have really good demonstration of how to take blood pressure, and we'll be practicing that in class in the next class meeting, I believe. Okay. So typical normal blood pressure is 120 over 80. A hypotension means below normal, more below normal. Remember, hypotension. Hypo is below, hyper is above. So 95 over 60 is definitely going to be hypotension. And hypertension, 140 over 90, is when you got to start. I think they start looking at it at about 130 over 90. So sometimes there's family history of high blood pressure. It's a good idea to keep track of that and make sure that your homeostasis stays good. If your body has to keep working really hard to keep your blood pressure under control, it's really wearing on your system. Here's some of the oxygen devices you may see in the hospital. There's liquid oxygen, there's portable oxygen, there's oxygen in the walls. You have to be aware of when you have a patient who's got oxygen, what their level of oxygen is set at, because it's specific for what their needs are to make sure that they have good oxygenation in their blood. So you're going to see when a patient comes with oxygen, usually you're going to see it in a tank, and it's measured in liters per minute. So you need to, like I said, if the transporters are getting their patients from the room in a bed and they're bringing their oxygen, but they're attached to the wall and they're going to switch it to a canister, you have to be sure the canister has plenty of oxygen in it before you move it, and you have to set it at the same flow rate as whatever the wall was oxygen was set at, so that the patient's getting the same amount of oxygen flow as they need. 21% of oxygen supplied by room air actually maintains homeostasis. So when oxygen is low, hypoxemia can occur, which is inadequate tissue oxygenation, which is causing the cardiopulmonary system to work a lot harder. Oxygen can be administered to correct hypoxemia, and if it's not corrected, you can get tissue hypoxia, which is where there is inadequate amount of oxygen at the cellular or tissue level in the body. Homeostasis can't be maintained, and oxygen needs to be given to reduce any of the clinical symptoms that patients would get from hypoxia. And you can see these symptoms as a change in the color of their skin. It might be blue, it might be bright red. Patient might be confused, they may be coughing, their heart rate will go faster, their breathing gets a little more rapid, they feel short of breath, they might start sweating or wheezing. There's a lot of symptoms when they're not getting enough oxygen. So if you change their oxygen flow rate when you move them from their room to a portable oxygen tank, you might see some of these symptoms if you've not got it set just right. So some of the devices that you're going to see, patients are going to have different types of masks, or possibly the nasal cannulas, or maybe the depending on what their needs are, they're trying to manage the flow and room air gases and also the oxygen mix, as well as some level of humidity. So some are attached to sterile water to add some humidity to their breathing. So low flow devices or delivery methods don't meet the patient's complete inspiration needs, and the patient doesn't necessarily have a set breathing pattern. They still just need a little bit of oxygen help to make sure they have a good mix and meet that 21% needed for homeostasis. So typical low flow rate systems would be the nasal cannula or simple mask, non-rebreather face mask that has the reservoir, like this one, the reservoir on there, and those are just some of the options for that. For high flow delivery methods, that's the patient is getting a fixed or precise oxygen concentration, and which meet or exceeds their inspiration needs. The room air gases are more precisely mixed with the oxygen before reaching the patient. So they receive a precise percentage regardless of their breathing pattern. And if they're on a ventilator, then not only are they getting that precise amount, but they're getting it in a precise manner. So their breathing rate is managed completely. Also, the CPAP machine that people wear when they snore, that's a high flow rate type of system. The bottom line with oxygen is never take the patient's oxygen off or disconnect it without the consent or supervision of the patient's attending nurses or physician or a respiratory care practitioner. You can always work around the masks and the tubing, but you never want to take that tubing off and that oxygen off. The patient may say, "Oh, I don't need it," but just don't take it off. Just leave it on because you don't know really what their status actually may be. All right, chest tubes and lines, endotracheal tubes, chest tubes, and central venous pressure lines. As techs, it's important that we know where these tubes and lines should be seen on our images, as well as making sure you've penetrated the area appropriately to see the lines in the tubes. The tubes have some amount of radiopacity so that they're visible on the images. But I've seen some tube placement images that are not adequately penetrated for the radiologist to assess the tube placement. So I don't ever want you guys to be that tech, because the radiologists are going to recognize that you're not paying attention to the technique that you're using or what needs to be done in order to see these tubes to be sure that they're placed in the right area. It can be very dangerous for the patient. So as you're working with your techs in the clinic and you're doing portables, find out, what the best techniques are to penetrate the lungs appropriately so that you can see these lines and tubes. Endotracheal tubes are used to manage respiratory complications. Tracheal intubation is usually through the mouth or through the nose, and they're typically going to need better oxygenation, so this allows them direct access, bypassing the first part of the breathing system on the patient to get right where the air needs to be, where the oxygen needs to be. Sometimes they have to do the tracheostomy. And what is an ostomy? Think about that. Basically an opening that gives access from the outside of the body to the trachea, other than through the upper airway. The endobronchial tubes are inserted into one of the main stem bronchi in case of pneumonectomy. Sometimes if the endotracheal tube is put into the right main stem bronchus, it can cause an atelectasis in the left lung. And basically that means that it's blocking the oxygen flow into the opposite. The tube will be blocking the oxygen flow into the other lung. So it starts to collapse. The left lung would start to collapse. On the AP projection of the chest with an endotracheal tube in a normal position, you can see where the arrow is that shows you exactly where it is. It's just above the carina, or the bifurcation into the primary bronchioles. Chest tubes are something you're going to see quite frequently in the hospitals with your inpatients. There's collapsed lung. There's air or fluid in the intrapleural space between the inner lining and outer lining of your chest cavity. And a tube is placed in there between your ribs into that space so that it can drain out the fluid or release the air, drain the air out of that area. You have the parietal pleura, which is the outer membrane attached to the inner surface of the thoracic cavity. And then you have the visceral pleura, which is a delicate serous membrane that covers the surface of each lung around the lung parenchyma. And it dips also into the fissures between the lobes. So what happens then is the intrapleural space, the space between the parietal pleura and the visceral pleura, is where fluid or air can develop. And the pressure then, once again, the atmospheric pressure or the pressure within the lungs is changed, and it makes the lung collapse. Sometimes there's blood that collects in that space. All of this creates pressure not only on the lungs, it creates also pressure then on the heart. It makes it very difficult for the patients to breathe. So they need to get that fluid or air or blood removed to allow them to breathe better and start to heal. So when you're doing a chest decubitus, what they're looking for when they tell you to wait for 5 minutes once the patient's on their side, that's to give the fluid or the air a chance to settle to the bottom. And really, as little as 150 milliliters of fluid can be visible on a lateral decubed chest. And that's about 5 ounces of fluid, which is about 2/3 of a cup. It just depends on how you can visualize that. So 150 ml is about 5 ounces or 2/3 of a cup. And if that gives you an idea of how much that is. And when you spread that over, 6 or 8 inches of space in the bottom of the lungs, it's not that much fluid, but they are able to visualize that. And atelectasis is diminished volume in the lungs that affects all or part of the lungs. So basically a collapsed lung. And here's what a chest tube placement looks like into the pleural cavity. Some common sites for the insertion of the chest tube. Where the tube's inserted really varies and depends on the lobes involved and where fluid or air is in the pleural cavity. If there's air in the pleural cavity, the tube is going to be inserted a little bit higher so that it can reduce the air in the cavity and return the appropriate pressure in there for keeping the lungs filled. If there's fluid in there, the tube maybe would be placed lower, more closer to the 8th intercostal space so that they could use gravity to help drain the fluid out. And an ostomy is an artificial opening in an organ of the body created during an operation such as a colostomy or a thoracostomy. So it's just basically a man-made hole on the body. So that's where the tubes would go into the opening or the ostomy into the thoracic cavity. When a lung is collapsed, it can sometimes cause the mediastinum to shift and it compresses the other lung. And expiration on a chest x-ray is really a good way to visualize a pneumothorax. And so that's why it's important to look at the history of the patient to decide whether you need to do inspiration chest x-ray or an expiration chest x-ray for pneumothorax. And here are some thoracostomy tubes. The one on the left, the tip is positioned at the 5th and 6th intercostal spaces to treat the pleural effusion, which is all of this, in the right lung. So you can see where the chest tube is right here. And on the left one, the upper lobe has a pneumothorax, and the thoracostomy tube goes in here, and it goes into the upper part to get the extrapleural air out and re-expand the lung. Central venous pressure line. These types of catheters are inserted into a large vein, like the vena cava. They are called central venous catheters or venous access devices, and you can use them for many different things in patients. Mainly they're used for chemotherapy or parenteral nutrition. So parenteral means other than through the alimentary canal, which is where you would normally eat by mouth, and you're going to get your nutrition through this venous line rather than by mouth. Maybe you're not able to eat, and this is a way to make sure you get the fluids that you need. If you need blood transfusions, that can happen there, and they can also go in this way and monitor your cardiac pressures. So these types of lines have been known by so many different names. Whoever developed them named them after themselves. So when I was first starting out, there were Hickman, Gresham, and Swan-Ganz catheters and PICC lines. And in this image, you can see the Swan-Ganz catheter tip starts up here in the jugular and comes all the way down the vena cava and into the heart, into the left pulmonary artery. This has gone quite a ways in, but it can also come down just here into the superior vena cava, and it can stop there. But this one they put all the way through into the left pulmonary artery. Portacaths you're going to see on patients who are currently having chemotherapy. They're going to put the port underneath the skin. So basically what they're doing is having a place where they actually can inject with an IV into this port, and then it goes into the vein entry into the superior vena cava, and can do the chemotherapy without having to find a vein every day for weeks at a time. And patients are really ill, you can't always find the vein. This is just a much easier way to make sure that they get the medications they need. It's a lot less invasive for them in the long run, and a lot more comfortable for them if they already have the port available. And it's covered by the skin, so they just basically inject through the skin into the port, right into the catheter, into the vena cava. On this patient, you can see that there is a peripherally inserted central catheter in the right arm. So it comes up in the arm and it goes up into the superior vena cava here. See if you can find the end of the nasogastric tube. And also they're pointing out that this patient has no clavicles, so it looks really interesting there in the lung field. PICC line placement. Regardless of the style used, the goal is to position the catheter tip into a central vein. And the preferred location is in the superior vena cava, and that's approximately 2 to 3 centimeters above the right atrial junction. So it's just above the right atrium, about an inch above, that's 2 to 3 centimeters. The superior vena cava placement is preferred because of its size. So the size and diameter of the vein will allow for fluids to get in there and be less caustic than if you have into the smaller peripheral veins, which may be a little more delicate. And the pulmonary arterial catheter helps to determine the pulmonary pressures. And this one goes into the superior vena cava, through the right atrium, through the right ventricle, into the pulmonary artery. And it's there that it will stay to check the pressure on the left side of the heart. And here's one that goes into the right. So you can put it in the left or the right main pulmonary artery. And the pressure, there's a balloon that inflates, that when it's measuring the pressure, it doesn't stay inflated all the time, or you'd have a real problem with oxygen getting into your lungs, but it does inflate during the pressure reading to ensure that it's stable. Here you can see how technique is a factor in whether you can see the tubes and the lines. So on this chest x-ray, you can see where the line is, the pulmonary arterial line is coming down through the superior vena cava, through the atrium, through the right ventricle, into the pulmonary artery, and all the way over into the right pulmonary artery, and comes out here. That's what that will look like on your chest x-ray. And you can see that pretty well, so that's good penetration through there. Not great for lungs, but it's good for the seeing the line. On this one, it's the same thing, but all of this stuff should be out of the way when you're taking these chest x-rays, especially if you're looking at line placement. The radiologist doesn't need to see all that extra stuff. It's hard enough when you're trying to visualize these things. So just be sure and move all the leads out of the way as much as possible, so it's not going to get mixed up with the catheters that they're trying to see for placement. This is the misplacement of a nasogastric tube. So this is the way it's supposed to look, right down the esophagus into the stomach. And this is where this one ended up. And then they put food in. It's liquid, of course, but right into the lungs. So it's really, really a good idea to be familiar with the correct placement and incorrect placement for the different types of the tubes and the lines that you're going to see, because clearly you need to bring that to someone's attention. If you see that there's a tube here, you want to make sure that somebody sees that before this happens. And although you need to recognize the problems related to tubes and lines, it is really out of your scope of practice to tell someone that the line is not in the right place, but within your scope of practice is to bring it to the radiologist's attention. And with digital and PACS and all of that, things, the radiologist looking at these images can happen a lot faster than it used to. So if you're ever concerned about a line placement, I would suggest you go to your radiologist and just, make sure that they look at it right away. So yes, it's important if you see something you think is amiss, then to let someone know. It is outside of your scope of practice, though, to tell someone that for sure the line is out of place or not malpositioned or whatever. That's not your place to do that. So conclusion for this part of the PowerPoint: vital sign assessment, objective information, non-invasive. You can evaluate the patient's immediate condition. You have to record everything accurately. The detail is important. how you're going to use, be careful with your oxygen with your patient so you don't disconnect it, so you don't have the patient take it off. When patients are on ventilators, don't trip over something and pull it out. You want to be really, really careful when you're doing portables on patients with ventilators. Oxygen flow should never be interrupted in order to perform any x-rays. And be familiar with the common chest tubes and lines, endotracheal tubes, NG tubes, central venous lines, all of that, so that you can help your radiologist do the best job. So this next part is a lot of is about cardiac monitoring and the EKG. It's a basic overview. Um, it's great to have a general understanding. It's really important. And an in-depth understanding is great if you're really curious about how things work or you just like to know details. Then that's up to you. It's not going to be a lot of depth on this because you're not going to use it a whole lot, but it really helps if you understand what you're seeing in emergency situations when you look at an electrocardiogram, or it could be EKG or ECG depending on the German way or the English way. So cardiac output is determined by two factors: your heart rate and your left ventricular output, or the stroke volume. And the stroke volume means it's the amount of blood ejected by the left ventricle in one contraction. So that's what they're looking at when they're looking at the cardiac monitoring. It can be the right side or the left side of the heart, but most commonly it's in the left side that they're measuring that stroke volume. And the electrocardiogram is looking at the electric assessment of the heart's ability to perform the contractions. So cardiac function, the heart functions to pump blood through the vessels into the vital organs and tissues. Oxygenation of the blood, all of this maintains a cellular oxygenation of the vessels and the body and the tissues. So generally, the systolic pressure is over 90, as we talked about in the last chapter. So you have 4 chambers of the heart, which you all know from your anatomy and physiology. So you have on the left heart, the left atrium, the left ventricle, and then on the right, you have the right atrium and the right ventricle. And the cardiac cycle, I posted a YouTube video on Blackboard that is a really good example of the cardiac cycle. So I'm not going to go into a lot of detail about this, but you do need to know what is systole, what is diastole, what is the ventricular contraction, and when the cardiac cycle starts and when it ends. So this is a really good example of that in picture form, but watch the video from YouTube. That is an excellent example of that as well. And the cardiac conduction system is the electrical system of the heart and how it creates the contractions and the relaxing of the heart cells, which are either the working cardiac cells, or their myocardium, or the specialized neural conductive cells, which create the electrical impulses that make the contractions and relaxation happen. I put a video regarding this as well on Blackboard. Really good explanation of how all of this works, when it's doing it right and when it's doing it wrong. So the working cells are the cardiac muscle or myocardium of the atria and the ventricles. And the specialized neural conductive cells originate in and transmit electrical impulses across the myocardium, and they regulate the rhythm of the cardiac cycle. The cardiac muscle cells are fused together into one sheet, which allows all of them to work as one. All the cells will work together as one. The atria sheet of cells is separated from the ventricle cell sheet by a layer of connective tissue that is right through here, that works to insulate between the two, the atrium and the ventricle. So when the electrical impulse happens at the SA node, then it transmits to the left atrium and down to the AV node. The AV node delays the electrical impulse slightly, and then it relays the impulse to the common bundle of His here, and then it bifurcates into the right and left bundle of His, and then separates into the Purkinje fibers, which give the impulse to the ventricles to cause them to contract. I find this whole process just incredibly amazing in how it all works. The video for this electrical system is really incredible, and what I really like about it is that it puts the EKG process right next to it, so you know what electrical stimulation is happening when, and how it fits into the EKG strip that you read. So the sinoatrial node is the pacemaker of the heart. The atrioventricular node passes the impulse down the bundle of His and separates to the right and left branch into the Purkinje fibers. And we talked about the specialized neurocells. They work independently of nerve or hormones, though the firing rates can be influenced by the autonomic nervous system. The autonomic nervous system includes the sympathetic and parasympathetic fibers, and it is also responsible for the involuntary functions of the human body. And I know I mentioned that earlier when with breathing. That's an involuntary function of the human body, as is the heart beating and the electrical impulses within the heart. That's all involuntary, and it's in the run by the autonomic nervous system. Sympathetic nerves can increase the activity or rate of cardiac impulses, where the parasympathetic nerves will slow their rate down. Parasympathetic nervous system controls homeostasis in the body at rest, and is responsible for the body's rest and digest function. The sympathetic nervous system controls the body's responses to perceived threat and is responsible for fight or flight responses. So both of these work together, and they make up the autonomic nervous system. Arrhythmias can arise in abnormalities in the electrical conduction of this system. So look at page 202 in your book for the details on the action potential. It's a little difficult to just explain in words, so the video is really going to help you understand what's happening when. So this is a diagram of the video that I was talking about that shows which part of the wave is happening and which part of the impulse is happening in the heart at the same time. So the unique tissue in the cardiac neural conduction system is going to allow the cell membranes to spontaneously depolarize at recurrent rates, meaning the heartbeat or the heart rate. And this is a process that's called automaticity. The cardiac electrical membrane potentials are all the cell membranes are positively charged on their outer surface due to the relative distribution of cations. So resting membrane potential is maintained by an active transport mechanism called the sodium-potassium ion pump. When the cell is stimulated, movement of ions in and out of the membrane alters the charge, reversing it to a resting potential. So then depolarization happens at this point, and the myocardial or working cells are stimulated to contract. Reversal of the ion flow then reestablishes the positive charge of the membrane, and it returns to the resting state, and the myocardial cells then relax. So the depolarization and the repolarization together are the action potential. So watch that video and you'll be able to see how that works. The isoelectric line is basically the baseline of the EKG, and it signifies the resting membrane potential. So the isoelectric line is basically this line through the EKG, the one that's the most stable. And then everything, the deflections are the points in the cycle that reflect the positive and the negative changes relative to isocentric, which means this line, the isoelectric line, or the isocenter of the time of the cycle. So here's an isocenter site, time of the cycle. Here is the isoelectric line that goes straight across. And these are deflections, points, positive and negative. So basically, the straight line in the middle, and then the peaks and valleys of the that emanate on the EKG. EKG analysis. This is the objective data that the EKG presents. These are the questions that hopefully this is going to answer. It'll give you the details about the data when you look at the EKG. These are common types of arrhythmias. If you look at pages 204 and 205, there are some really great examples of the EKGs showing normal sinus rhythm, the common arrhythmias, and finally asystole that has no evidence of any neuroconductive activity, and death is imminent at that point. PVCs are when an extra impulse is fired from within the ventricle. That's basically premature ventricular contractions. The most common arrhythmia would be atrial fibrillation. Generally, it's not life-threatening, but it does have the potential to cause a clot, a blood clot in the atrium because it's not emptying properly. Ventricular tachycardia is when the heart rate is abnormally high, exceeding 100 to 240 beats per minute. And that's happening in the ventricular area. Ventricular fibrillation is the most extremely life-threatening arrhythmia, and that is when the ventricular muscle fibers are disorganized in their contraction, and actually no blood is being pumped because it's just erratic and sporadic and there's no rhythm to it whatsoever. So blood is not actually getting pumped out from the heart, which then the next step is asystole, which is flat line, which is that isoelectric line just means there is actually no activity whatsoever, no departures from the isocentric line. Many of the arrhythmias can be treated. Some of the treatments are invasive and some can be managed with medication. I'm not going to go into a lot of details about this because that's, these are things that you're going to learn as you go through at the hospitals. Just knowing that in these general procedures that are possible for managing arrhythmias is really important. So basically, they're classified by their area of origin, either the atria or ventricular, or by the speed. So tachycardia or bradycardia, or the speed of the heart rate. So bradycardias are typically involve the SA or AV nodes abnormalities. So that's the electrical impulses. They're not transmitting properly, and that causes the heartbeat to slow down. While tachycardia involves the atria or the ventricles, and it causes the heartbeat to beat much faster. So many more people are surviving heart issues now than they ever have before, based on our ability to recognize these rhythms, and now that we have these treatments for these issues, then people are surviving much more than they used to. You'll frequently see implanted pacemakers and defibrillators, and these basically manage either the rate or pace of the heart, and or um, the they act as the SA node is the pacemaker of the heart, and maybe it's not functioning properly, so they put one in that has the electrodes that will cause the electrical impulses needed to keep the heart beating at a regular rhythm. So that was really quick with the cardiac cycle and EKGs, because you really don't need to know that super in depth, but you do need to understand what these different arrhythmias are, how the cardiac cycle works, how the electrical conduction works and helps with the heart beating. And that way, if you're in a situation where you're on a code or whatever, you can help in the situation as much as possible. And just be aware of your patient's condition at all times. That's one of the important responsibilities that you have. All right, that's it for this week, and midterm is coming up next week, and I will see you guys on Monday.